In this radiographic image analysis, we will cover the cervical vertebra. Let's begin with the AP axial projection of the cervical vertebra. Image analysis guidelines state for this AP axial cervical vertebra projection that the spinous processes should be aligned with the midline of the cervical bodies. The mandibular angles and mastoid tips should be demonstrated at equal distances from the cervical vertebra. The articular pillars and pedicles are symmetrically visualized lateral to the cervical bodies. Distances from the vertebral column to the medial clavicular ends are equal. The intervertebral disc spaces should be demonstrated as open. Vertebral bodies are demonstrated without distortion. Each vertebra's spinous processes are visualized at the level of its inferior intervertebral disc space. The third cervical vertebra should be demonstrated in its entirety. The occipital base and mandibular mentum are superimposed. The long axis of the cervical column is aligned with the long axis of the exposure field. The fourth cervical vertebra should be demonstrated at the center of the exposure field, and an area from the superior portion of the C3 to T2 and the surrounding soft tissue should all be included within the exposure field. So let's discuss central ray angulation and the misalignment in an AP axial projection. Misalignment for the central ray and the intervertebral disc spaces for an AP cervical projection will result in closed disc spaces, distorted vertebral bodies, and the projection of the spinous processes into the vertebral bodies. In an AP axial C-spine with insufficient central ray angulation or no angulation used at all, the resulting projection demonstrates closed intervertebral disc spaces. Each of the vertebral spinous processes are demonstrated within the vertebral body, as you can see demonstrated here, whereas each of the vertebral spinous processes should be visualized at the level of its inferior intervertebral disc space. These misalignments can occur also as a result if the head and the upper cervical vertebra are tilted anteriorly towards the X-ray tube for the examination. So it is our responsibility to make sure the positioning of the AP axial projection is within guidelines so that we can demonstrate the anatomy within the evaluation criteria. Now, with excessive central ray angulation, or if the cervical vertebral column was extended posteriorly for the examination, as like with a kyphotic patient, the resulting projection demonstrates closed intervertebral disc spaces. The vertebral spinous processes will be demonstrated within the inferior adjoining vertebral body, and you will see elongated uncinate processes. So therefore, again, we need to make sure our central ray alignment is anywhere from 15 to 20 degrees cephalic to appropriately demonstrate this projection. So moving forward, let's talk about the positioning of the mandibular mentum to the occipital base and its effects on the AP C-spine, AP axial, C-spine projection. We know that accurate positioning of the occiput and mandibular mentum is achieved when the lower surface of the upper incisors and the tip of the mastoid processes are aligned perpendicular to the IR. With this position, you might expect that the mandible to be superimposed over the upper cervical vertebra, but this is not the case because the cephalic central ray is used and that projects the mandible superiorly. Mispositioning of the occiput and the mentum results in a projection demonstrating an obstructed upper cervical vertebra. If the mandibular mentum is positioned superior to the occipital base, meaning the head's tilted too far backwards, the upper cervical vertebra are superimposed over the occiput, as demonstrated in this image. So we must remember that we need to position the face forward, placing the mandibular angles and the mastoid tips at equal distances, and ensuring that we have the lower surface of the upper incisors and the tips of the mastoid processes perpendicular to that IR for the AP axial C-spine vertebra projection. So when the mandibular mentum is demonstrated inferior to the occipital base, meaning the chin is tucked too far downward, it actually superimposes over the superior cervical vertebra. So, and as you can see in this image, the third vertebral body is superimposed. So we must, again, just make sure that we have positioned the patient according to criteria in order to obtain the appropriate projection. So let's review our first practice analysis of the AP axial cervical vertebra projection. We can see that the cervical bodies are obscuring the intervertebral disc spaces, so therefore our disc spaces are closed. The vertebral spinous processes are demonstrated within the vertebral bodies, which should all indicate to you that we have a central ray angulation issue here. Also, looking at this image, the mandible is superimposing over the third cervical vertebra here, which should tell you we have a positioning issue as well. So in order to correct these anatomical misalignments for a repeat projection, we need to increase the degree of central ray angulation, elevate that chin until the lower surface of the upper incisors and the mastoid tip are aligned perpendicular with the IR. In our second practice analysis here, we can see that our intervertebral disc spaces are again closed. The posterior and posterior-inferior aspects of those cervical bodies are obscuring those intervertebral disc spaces. You can see that these uncinnated processes are elongated, which should indicate to you that there is a central ray misalignment. Also, each vertebral spinous process is demonstrated within the inferior joining vertebral body. This says that basically our central ray was angled excessively and we need to decrease that angulation in order to obtain the appropriate projection. So now let's move on to the cervical vertebra C1, C2, the atlas and axis, or otherwise known open mouth projection. Radiographic image analysis guidelines for C1, C2, the open mouth projection, state that the atlas should be demonstrated symmetrically seated on the axis with the atlas's lateral masses at equal distances from the dens. The spinous process of the axis is aligned with the midline of the axis's body. The mandibular rami are visualized at equal distances from the lateral masses. The upper incisors and occipital base should be seen superior to the dens and the atlantoaxial joint. Your atlantoaxial joint space should be demonstrated as open. The dens should be demonstrated at the center of the exposure field, and the atlantoaxial and occipital atlantal joints and the atlas's lateral masses and transverse processes and the axis's dens and body are all to be included within the exposure field for this projection. So I wanted to talk a little bit about central ray alignment for the cervical vertebra open mouth projection in a trauma patient. Typically, trauma patients come over with a C-collar on, and this means that the patient's head and neck cannot be adjusted in the initial projections until the radiologist has cleared that projection. So in this position, the line connecting the incisors and the mastoid tip is at approximately a 10-degree caudal angulation, and the upper incisors are at an angle with a central ray that will result in less magnification of them because of the foreshortening of the resulting projection. Because of that upper chin tilt in the C-collar, the occipital base is actually positioned directly beneath the dens and the atlantoaxial joint space. So what do we do to obtain this projection in this position? Well, we can use the infraorbital meatal line, the line connecting the inferior orbital rim and the external ear opening. It's easy access to in a patient wearing a C-collar. When the central ray is aligned with it, it can be used to determine the needed angulation to obtain the open mouth projection. So for trauma positioning, insufficient caudal angulation will cause those upper incisors to be demonstrated superior to the dens, and the dens to be superimposed over the occiput. So in order to correct this positioning error or central ray angulation, we need to increase that caudal angulation. Conversely, if we are trying to image an open mouth projection and we get the resulting projection, this is demonstrating excessive caudal central ray angulation. You can see that the occipital base is demonstrated superior to the dens, and the upper incisors are superimposed over the dens. Therefore, we need to decrease some of that angulation so that we can obtain the appropriate projection. In this first Practice analysis of C1, C2, the open mouth projection. You can see that the occipital base is superimposed over the dens. The upper incisors are demonstrated superior to the occipital base instead of superimposing. This indicates to us that the chin was elevated. Also, there's a little bit of rotation seen because when analyzing this image, you can see that the atlas's lateral masses to the dens and from the mandibular rami to the dens are narrower on the left side than on the right. So the face was rotated towards the right side. In order to correct this imaging, for a repeat image, we need to lower the upper incisors until the lower edge of the upper incisors and mastoid tip are aligned perpendicular with the IR and rotate that face towards the left side until it is facing forward. In the second practice analysis, we can see that our atlantoaxial joint space is closed and the dens is superimposed by the upper incisors. This should demonstrate to you that there is some mispositioning here that we need to correct. Also, there is slight rotation demonstrated in this image. You can see that the distances from the atlas's lateral masses to the dens and from the mandibular rami to the dens are narrower on the left side than on the right. The face is actually rotated towards the right, and so therefore, in order to correct this imaging, we need to rotate that face towards the left side until it is forward, and raise the upper incisors until that lower edge of that lower incisor and the lower edge of the upper incisor, and mastoid tip are aligned perpendicular with the IR to sufficiently attain the projection. So moving forward, let's talk about radiographic image analysis guidelines for a lateral C-spine projection. Radiographic image analysis guidelines for a lateral C-spine include that the anterior and posterior aspects of the right and left articular pillars and the right and left zygapophyseal joints of each cervical vertebra should be demonstrated as superimposed. The mandibular rami are to be superimposed. The spinous processes are demonstrated in profile. The superior and inferior aspects of the right and left articular pillars and zygapophyseal joints of each cervical vertebra are superimposed. The intervertebral disc spaces are demonstrated as opened. The posterior arch of C1 and the spinous process of C2 are in profile without the occipital base obstructing them. The bodies of C1 and C2 are to be demonstrated without mandibular superimposition, so it's important to elevate that chin so that the positioning of the acanthomeatal line is parallel with the floor for this. The long axis of the cervical vertebral column is aligned with the long axis of the exposure field. The fourth cervical vertebra should be demonstrated at the center of the exposure field. And the sella turcica, the first through seventh cervical vertebra and superior half of the first thoracic vertebra and the surrounding soft tissue should all be included within the exposure field. As discussed in the image analysis guidelines, it's important to point out that the acanthomeatal line alignment, it should be parallel with the floor for this lateral C-spine projection. Otherwise, one or both of the mandibular rami are superimposed over the bodies of C1 and C2, as demonstrated in this image. So let's talk about lateral C-spine projection and rotation. When the torso or the cranium is rotated, the pillars and the zygapophageal joints on one side of the cervical vertebra move actually anterior to those on the other side, as demonstrated here, whereas they should be superimposed on, and one mandibular rami is demonstrated anterior to the other, as demonstrated in this image. Because the two sides of the vertebra are mirror images, it is very difficult to determine from a lateral cervical projection which side of the patient is rotated anterior and which is rotated posterior. You can use the mandible and the magnification of which side is actually demonstrated in profile as a moderate reliable clue, but the best thing to do is go out, look at your positioning of the patient, make sure that patient is in that upright lateral position with the mid-sagittal plane of the torso and the cranium aligned parallel with that IR. Align that interpupillary line perpendicular to the IR. Position those shoulders on the same horizontal plane and elevate that chin so the acanthomeatal line is parallel with the floor. This image here is a demonstration of a little bit of head tilt and rotation and what it does anatomically to form some misalignments. Again, we can see zygapophageal joint spaces are not particularly superimposed, and you can see the intervertebral foramina here, which should not be demonstrated in a lateral projection. Let's talk about head tilt a little bit more in depth. If the head is tilted away from the IR, we'll see a little bit of separation between the right and left articular pillars. Also, the zygapophageal joints of the upper C-spine and the inferior cortices of the cranium right here will be misaligned, and the mandibular rami are positioned without superimposition. Also, the posterior arch of C1 will remain in profile. So this image here demonstrates head tilt away from the IR. In order to correct this positioning error, you want to make sure that the interpupillary line is perpendicular with the IR, and making sure that the acanthomeatal line is parallel with the floor. In a lateral projection where the head tilt is towards the IR, there'll be separation between the right and left articular pillars. The zygapophageal joints of the upper C-spine and the inferior cortices of the cranium and mandibular rami will be demonstrated without superimposition. In head tilt towards the IR, the vertebral foramen of C1 is actually demonstrated in profile. So again, we want to make sure that IPL line is perpendicular to the IR. Your acanthomeatal line is parallel with the floor in order to obtain the appropriate projection. So now let's review a practice analysis of the lateral cervical vertebra. By looking at this, you can see that the articular pillars here and the zygapophyseal joints are not superimposed as they should be. The joints on one side of the patient are situated anterior to those on the other. This should indicate to you that there is some degree of rotation. In order to correct this image for our repeat, we would need to rotate the patient until the mid-coronal plane is aligned perpendicular with the IR. When evaluating this second practice analysis of the lateral cervical vertebra, you can see once again there's some degree of rotation because of the articular pillars and zygapophyseal joints not being superimposed, so that should tell you there's some rotation. And also, the mandibular rami here are superimposing over the cervical body of C2. Therefore, we have a little bit of mispositioning. Our patient's chin wasn't adequately elevated. In order to correct this, we need to, again, rotate that patient until the mid-coronal plane is perpendicular with the IR, and make sure that we elevate that chin until the acanthomeatal line is parallel with the floor. So let's discuss this last practice analysis of the lateral cervical vertebra. You can see that the inferior cortices here of the cranium and the mandibular rami are not superimposed. The vertebral foramen of C1 is actually visualized right here. Also, the base of the skull is in the process as well. The right and left articular pillars and zygapophyseal joints demonstrate supro-inferior separation here. You take a look at that. This all indicates that the head and upper cervical vertebra are actually tilted towards the IR. So in order for us to correct this imaging error, we need to ensure that our interpupillary line is aligned perpendicular with the IR, and that the acanthomeatal line is aligned parallel with the floor for that proper positioning for the lateral cervical vertebra projection. Moving forward, let's talk about radiographic image analysis guidelines for a PA or the AP axial oblique cervical vertebra projection. Radiographic image analysis guidelines state that the second through the seventh intervertebral foramina should be demonstrated as open, demonstrating uniform in size and shape. The LPL and RAO position, the structures best shown are the right pedicles in profile, and the left pedicles are aligned with the anterior vertebral bodies. In an RPO/LAO position, the left pedicles are demonstrated in profile, and the right pedicles are aligned with the anterior vertebral bodies. The inferior outline of the outer cranial cortices are demonstrated about a 1/4 inch with distance between them. In the inferior mandibular rami, demonstrate about ½ inch between them. The posterior arch of the atlas and vertebral foramen are seen. The intervertebral disc spaces are open. The cervical bodies are seen as individual structures and are uniform in shape. The fourth cervical vertebra is at the center of the exposure field, and the first through seventh cervical vertebra, the first thoracic vertebra, and the surrounding soft tissue are all included within the exposure field. When obtaining an PA axial oblique projection, please be cognizant that the central ray angulation does change. It requires a caudal central ray of 15 to 20 degrees. Also, the structures best shown in an PA rather than an AP projection are the intervertebral foramina and pedicles closest to the IR in the PA axial oblique projection. All other positioning, SID, and all other factors remain the same. In this first PA axial oblique projection here, I wanted to demonstrate what insufficient cervical obliquity looked like. When this occurs, you'll see that we are actually at less than 45-degree angle with the IR. The intervertebral foramina are actually narrowed and obscured, and the pedicles of interest are foreshortened, as demonstrated in this image. In this PA axial cervical vertebral projection, it was taken where we have adequate positioning in the upper portion of the cervical vertebra, but in the lower portion, we are excessively rotated. Again, the pedicles of interest are partially foreshortened, and the opposite pedicles are aligned with the midline of the vertebral bodies. Again, the zygapophygeal joints that are demonstrated without vertebral body superimposition are demonstrated in profile. We must remember that because it is possible for the upper and lower cervical vertebra to be rotated to differing degrees in the same projection, we need to truly evaluate the entire cervical vertebra for proper rotation. So let's discuss our first oblique projection practice analysis. Looking at this projection, we can see that the pedicles here and intervertebral foramina are obscured. The medial clavicle here is superimposed by the vertebral column, and this should just indicate to you that the patient wasn't sufficiently rotated to that 45 degrees that we need to open up those intervertebral foramina, and so that we can get a good view of those pedicles. In order to correct this, we just need to increase the degree of obliquity until the mid-coronal plane is placed at that 45 degree with the IR. In this last practice analysis of the PA axial oblique cervical vertebral projection, we can see that our intervertebral disc spaces are closed. Your cervical bodies are distorted. The zygapophygeal joint spaces are demonstrated, and this should indicate to you that either the patient's vertebral column is not aligned parallel with the IR, or we have some misangulation of the central ray. Because this is a PA axial projection, we need to adjust that central ray caudally until it is aligned with the intervertebral disc spaces to correct this imaging. Also, we could ensure that the cervical vertebral column is parallel with the IR for this projection to correct the imaging misalignments. This concludes the radiographic image analysis for the cervical vertebra. Thank you for participating, and if you have any questions, please feel free to reach out to me via email or while I am out at clinic.